Welcome to Podcast UK.
In this, one of our shorter Cappuccino Break episodes, we invite you to sit back and relax with your favourite hot drink and enjoy this mini podcast of plastic surgery. Hello there, my name is Matt Stone. I'm a plastic surgery registrar from Yorkshire, and in this Cappuccino Break mini episode, I'm going to be talking about WALANT. Now, many of you will already be very familiar and may be using a lot of WALANT in your practice, but I think it is something that's quite variable across the UK, and it's a really useful technique that we all definitely need to know about. So firstly, what is it? Well, it's kind of like it says on the tin. WALANT is wide awake, local anaesthetic, and no tourniquet. Wide awake meaning no sedation or general anaesthesia, local anaesthetic, which is predominantly lidocaine with adrenaline using a tumescent infiltration field block approach, and no tourniquet, because the adrenaline is providing your hemostasis. Now, the techniques and principles that we call WALANT today were really developed by Dr. Don Lalonde, although he wasn't, and has never claimed to be, the first person to use local anaesthetic with adrenaline in hand surgery. Indeed, Dr. Lalonde says that much of his work was built on what he saw his mentors do in his training. I think it's really important to make absolutely clear for anyone that may still be in doubt that the myth that injection of local anaesthetic with adrenaline into a finger risks digital necrosis or finger loss is just that, a myth. I think this is now very widely recognised as being untrue. However, it's something I was taught only 10 years ago in medical school, and it still remains in many textbooks. There are published series of thousands and thousands of cases of finger surgery using WALANT without a single digit being lost. Now, the normal concentrations of adrenaline we use in WALANT surgery tend to be either 1 in 100,000 or 1 in 200,000. However, there are over 100 cases published in the literature of injection of lidocaine with high concentration adrenaline, that's 1 in 1,000, so 100 times at least more concentrated, without a single reported case of digit loss. Interestingly, Don Lalonde himself famously volunteered to have a 1 in 1,000 injection of adrenaline into one of his fingers, which just goes to show quite how confident he was that he wasn't going to lose his digit. Something else that he said was that he would continue to use adrenaline in fingers until such time that he had to inject phentolamine to reverse it, and so far that day has never come, despite him performing over 2,000 operations like this. Phentolamine is an alpha-1 receptor blocker, and it remains an important safety net for those using WALANT, along with warming and massaging digits. Within 1 to 2 hours, it can reverse the effects of adrenaline and restore perfusion, although, as I say, Don Lalonde himself says it's never been needed in his practice to save a finger. So what can you do with WALANT? Well, the answer is you can do most things, both emergency procedures and elective cases as well. Thinking about trauma cases, it will allow you to safely repair digital nerves, flexor tendons, extensor tendons, but also fracture fixation under WALANT. And thinking about elective cases, it ranges from carpal tunnel decompression to Dupuytren surgery, cubital tunnel decompression, and even trapeziectomies. There are a whole range of different procedures that you can very efficiently and safely carry out. I think it's fair to say there's definitely a learning curve, and if you're starting out with this, you want to start out with some simpler procedures as you build your confidence and experience. So can you use WALANT in everyone? Well, definitely not. I think it's important to say that if you start out with a finger where you're concerned about the perfusion, injecting adrenaline into it is not going to improve that. So certainly, you wouldn't want to be using it for fingers where you suspect that you've got 2 vessel injuries, where you're going to have to potentially do revascularization of a digit. You also want to make sure that people don't have preoperative conditions that are going to affect the perfusion of their fingers, things like scleroderma, Raynaud's, peripheral vascular disease, or indeed sickle cell. It's also not a great choice for things like cases of deep-seated infection or deep penetrating proximal injuries, which would be better done under general anaesthesia or brachial plexus block. So what are the advantages of WALANT? Well, the first thing is that you obviously don't need an anaesthetist, and this can give you a lot more flexibility when arranging your operating lists. This can facilitate you to operate outside of main theatres, such as in a clean room environment, but it can also allow you to plan more operating lists. This is what we found locally. We wouldn't have been able to get anaesthetic cover for all of our new lists. There are also logistical and financial benefits for hospitals using this model. In many patients where there are concerns about the risk of regional or general anaesthesia, WALANT can still be used safely. Not using a tourniquet also means you avoid the reactive bleeding that occurs when this is released, and the breakthrough pain that can occur when performing longer procedures under regional blocks. However, one of the main advantages compared to brachial plexus blocks or general anaesthesia is that patients can still preserve active movement. So this means that if you're doing, for instance, a flexor tendon repair or a tenolysis, you can actively test the movement of that tendon on the table. This of course isn't possible if the patient is under general anaesthesia or has had a brachial plexus block that has anaesthetised the innervation to the forearm muscles. Because your patient's also awake and hasn't been given any drugs that are going to affect their ability to interact, you can talk to them, explain what's happened, counsel them, and indeed answer any questions that they may have. I think on the whole, patients generally really do like WALANT. It has a number of advantages from their point of view. It avoids the need to fast, their recovery is often very quick, they can go home pretty much as soon as the surgery is finished, and it's just generally simpler, avoiding the need for cannulas and many of the preoperative tests that patients may require if they were having a general anaesthetic, such as blood tests and ECGs. That's not to say that it isn't without some concerns for many patients. Things that I found when I speak to patients is that they're worried about feeling pain, or indeed seeing things that they may find distressing. But I think in the most part, if you explain to patients what to expect, you can counsel them, and many of these patients are absolutely happy to try WALANT and have a very good experience using it. I think improving the quality of injections to minimise any discomfort can be helped by using things like bicarbonate to buffer your local anaesthetic, as well as using as fine a needle as possible to minimise injection pain. Of course, if your patient really isn't on board, then they're not a good candidate for WALANT and you should use a different option. The use of WALANT is not without its challenges. It's very different from using a tourniquet. With a tourniquet, you get an immediate bloodless field, whereas with adrenaline, it takes a bit more time to work. Ideally, you need to wait at least 20 to 30 minutes to let it have good effect. And so I think the most efficient strategy for this, and what we do in my unit, is at the start of the list, after doing all the normal safety checks you would do in theatre, you give the local anaesthetic to the first couple of patients on the list. This means that by the time you're finishing the first case, the local anaesthetic for the second case has had time to cook and is really having a very good haemostatic effect. This then means that you can give the local anaesthetic to the next patient after them, and essentially this way, leapfrogging, so that you're always staying at least one patient ahead of yourself and ensuring that the patients are always having both effective local anaesthesia but also with a good haemostatic effect. I think the other thing that's really key to say is that in my experience you don't get a completely bloodless field like when you're using a tourniquet, but it definitely reduces bleeding to a point where it's very manageable and you can safely and effectively carry out your surgery. So in summary, while I'm not claiming to be an expert in the WALANT technique, I think it's a really useful part of any hand surgeon's armamentarium. Now if you're interested and want to find out more, there's loads of great resources out there. The British Society for Surgery of the Hand has some great resources on their website, and if you go to walant.surgery, you'll come to the WALANT University, set up by Don Lalonde and Ali Phillips, and they have some really great resources, including some brilliant videos. It's free to register, and for anyone trying out WALANT for the first time or wanting to learn more, it's a really great resource. I hope that's been interesting and useful. Enjoy. Podplast UK is a collaboration between UK plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.